So here we go. This is the positioning for the forearm and elbow. And I do want to make a couple, oh, nope, not that. Of course. I didn't even read it. There are quizzes built into this if you noticed. Anyways, I want to make a couple notes on some movements and things like that before we get into positions, okay? For one, the forearm itself has to be done in what we call the AP position, but the forearm can pretty easily pronate, right? So this would be the correct AP, palm up like that, but the forearm also does pronate. If you happened to forget that and accidentally do this forearm x-ray, radiograph with the palm down, you will quickly notice that with the hand pronated, palm down, the radius and ulna actually cross over each other. Okay, so if you didn't already know, when you turn your palm down, your radius is now crossed over on top of your ulna, okay, like what is shown here. So the radius and ulna superimpose on each other when we pronate our hand. By the way, people with radial head injuries have a lot of trouble with supination and with extreme pronation. Like they're gonna probably be stuck kind of like this. They're not gonna want to go into supination very much. And you're doing it right now, right? You just did it. Have you had this experience, right? Because they get to here, right, and then it hurts to go to full supination. Why? Because as you're supinating the hand like that, right, you're having to take, and if you focus on the radius up here, radial head up here, as you supinate the hand, the radial head has to roll, right? That's going to mean if the radial head's fractured, that you're taking a fractured bone and moving it, right? That always hurts, okay? So what often happens is when patients go to supinate and they have these injuries, they do exactly what you just did. They do that. They try to lay their arm out because they can't do the supination with their forearm, so they make up for it with their upper arm, and this is no good. Okay, I'll tell you later why exactly this is no good, but you can see, right, it just doesn't look right. Don't look like I'm positioned correctly, but we'll run into that issue, which is why we have the trauma laterals. Okay, anyways, there you are. Radiographically, you can see this, right? A is the supinated version. B, they are over-rotated, laterally rotated. And C, they've left their palm down. Okay, it changes our view on the elbow, right? Now, these are actually correct views of the elbow for what they're being used for. B is called the lateral oblique. C is called the medial oblique. These are positions we'll have to learn. But if you're talking about the forearm, right, this is completely changing our view on the forearm as we do these different supination, pronation movements. Another thing I'd like you to get used to for the elbow, what do we see on radio? Like, what are the 4 different types of things we can see on radiographs? What shows up?
Bone.
The obvious one's bone, right?
Bone, hardware, soft tissue.
So let's say bone. Okay, what's less dense than bone? Joints are going to be pretty much, see-through, right? Radiolucent, yeah. Muscle, right? So we see bone, we see muscle, okay? We see fat, bone, muscle, fat, okay? And what's the thing that's less dense than fat that we see inside the body? We did deal with a lot of it in the chest. Not vessels, but air, right? Muscles are dense because they're water-filled or blood-filled, right? Fluid-filled. Air. So we can see, again, bone, muscle, fat, and air, okay? And you mentioned hardware, right? Hardware is more dense than bone. So if you want to add a 5th thing that's like not a naturally occurring thing, it's hardware, right? So 5 things total. But the point is that we can see fat, okay? Fat is less dense than soft tissue. Soft tissue is just muscle, okay? And so it's going to show up darker. Now, under normal circumstances, we have fat surrounding and padding areas on our body, these joint spaces and articulations on our body. we have a fat pad in the olecranon fossa on the back of our humerus. That fat pad lays up against, so normally this fat pad is stuck way up against the humerus, and it allows for, something's got a pull here, right? A tendon's got a pull attaching to our triceps muscle, right? The fat pad lays up against the bone to allow something kind of padded for that tendon to pull across, okay? However, and we see that anteriorly, there's a fat pad anteriorly over the anterior humerus and over the radius. They're normally right up against the bone, these pads of fat, okay? But when there's trauma, when you injure a bone, can everybody spot the injury? What's fractured? What's injured? The olecranon's back here. Olecranon looks roughly intact, but it is an olecranon fracture. But they fractured right at the trochlear notch. Okay, this circle is cut in half, right? So there's our big fracture here. This is not a growth plate. This is a traumatic injury fracture. They fell and hit their olecranon on something and broke it off. But anyways, when there's a fracture, a traumatic injury to the body, what you're going to get is you're going to get lots of bleeding in that space, okay? The blood is going to fill the space around the bone, and it's going to push the fat pads away from the bone, okay? When fat pads get pushed away from the bone, we can now see them. We couldn't have seen them before. Now to help us, they have outlined where these fat pads are. I know it's hard to see, but you have soft tissue, and in the areas where the fat pads are, when there's trauma, these fat pads, which are normally pushed up against the bone, are going to be pushed outward, okay? And we see these as little dark areas, little radiographically dense or dark areas on the x-ray. This one's not doing a great job of showing us the fat pads, but they are here. They are right in this area, right in that area too, okay? When we see fat pads, dark areas where they shouldn't be, we know where the fat pads are normally, up against the bone. When we see them pushed into the space away from the bone, that's evidence that there was trauma to the bone. So sometimes when a physician cannot see an obvious fracture, but sees fat pads, those are signs that there's a fracture that they are missing, okay? That we cannot see radiographically, but is actually there, okay? We have them in the wrist, we have them in the elbow. So one way of diagnosing a radial head fracture, for example, is by seeing this fat pad that's anterior to the radius, okay? And we see the fat pad present, and the physician goes, well, I can't see a fracture to the radial head, but when I do the exam on them, I think they've got a fracture, okay? And then radiographically, I saw a fat pad right around the radial head. So they can diagnose the fracture without actually seeing the broken bone itself. Again, not a great job of showing fat pads here. Good job of showing the fracture. But because of the limitations on the display and the computer, it's harder to see these fat pads themselves. But they are there. And then when they outline them too, that totally ruins it. But anyways, they're there. The point is where they are outlined is where the fat pads will show up, if they're going to show up at all. Okay, so it's a big thing in the elbow because the elbow can be kind of complicated. Presence of fat pads after trauma. Let's talk about some positioning considerations that are just general ones for the upper limb, and you've heard some of these before. Vanessa, this is mostly to help you out to get you started, okay? We always keep a minimum distance from the source of radiation, our X-ray tube, to the image receptor. That minimum distance is 40 inches for all extremities. We refer to this as our SID, or source to image distance. We always shield the gonads. We always shield the gonads. What are gonads? Ovaries and testes, right? We always collimate. Unless Vanessa's been very, very good and has read all this already, one of you tell Vanessa what collimation is, please, and thank you. What's collimation?
Adjusting the light to the area of interest.
What do you mean light? Like I've got light in the room.
Central ray.
She doesn't know what a central ray is.
The path of the radiation, the projection.
He's like, you figure it out.
So
It's in the book, it's on the page.
it's in a page in the book. All right, so let's make this clear, right? When we take an X-ray, like all of those up there, you notice there's a black kind of square around the body part, right? That black square is where the radiation exposure happened, okay? So if you notice like this little cute little baby bird, right? Black square, everything else, all of this was unexposed film, okay? These are films, right? But inside of that black square got all exposed, okay? We can change the size of that radiation field, and that's done with a device called a collimator. Okay, it hangs on. Most of you know this. It hangs off the bottom of the X-ray tube. A button that you turn on a light, so you can see representing where the radiation field will be, such as what's being shown there, and you can change that size. Right. Underneath her is that rectangle. We'll call that the image receptor, the thing that catches the image. What would hold a piece of film or holds a digital receptor nowadays. And we can change the size of that radiation field or light field in the case of just seeing the light. The light represents the radiation. We want to show all four sides. Notice how that little birdie up there, we can see all four sides. That collimated field is not as big as the piece of film is, right? That little birdie's tiny. We don't need the light field to be that big. These elbows, also small body parts. We did not need the light field to be larger than the body, or much larger than the body part, right? Collimate on four sides when possible. Align the body part to the image receptor so it's not diagonal across the receptor. Patient ID markers visible. Good. Let's do our positions. Zoom past the wrist stuff, of which there is a lot. Let's talk about the forearm. So to do that, you want to find the right page for this, which I will illuminate for you in a moment. 162 in the text is where we'll want to start. So using a combination of notes on screen in your textbook, 162, we'll start with the positions here. AP forearm, okay? Now with these worksheets, you'll notice that there's room for three positions on each page. You're going to put the position where it says projection. So if you look at the bullet points on each one of these, it says projection. Projection is another way to say position. The projection we're doing is called the AP forearm. All right. Why do we call this AP? What's the meaning?
It's an anatomical position, palm up.
Palms up, right? What does the word AP mean? Anterior, posterior, right? What is that describing? What is it telling us? What information am I getting?
It's telling you the anterior to the posterior.
What's anterior to posterior? You're right.
The image?
The image is a front view like this, right? But what it's actually being told here is the path that the X-ray beam takes. This is why we call it the projection, right? So if I shine a flashlight at you right now, right? The light came from my flashlight, and if I shine it at you right now, it's going to hit your front first, right? Now, if it's an X-ray beam, it can travel through you, where a flashlight just stops, right? It reflects off you, but an X-ray beam goes right through you. If I shine it at you right now, so this is an X-ray beam now, it's going to enter your front and exit your back, anterior to posterior, right? Or AP, yeah? For the forearm palm up, it's going to hit the front first. The X-ray beam's coming from up above. It's going to come down, enter the front of the forearm, exit the back of the forearm, AP, right? Otherwise known as like a front view, right? But the correct term we're going to use is AP. This is why we call it a projection. These are describing the path that the X-ray beam takes. Good, good, good. Okay, with that said, AP projection forearm. Now you'll notice, I've said this before, but it's worthwhile to restate. You'll notice the things that I've listed on here for you to write in: projection, patient position, part position, central ray, evaluation criteria, right? These are some things to write in, but you'll notice that the textbook has more than that on each page, okay? So the things that I won't include are clinical indications for the worksheets. Clinical indications, when it says clinical indication, what does that mean to you? Marco, what does clinical indication mean?
Is anything visible that you see? Is it like a fracture, like a pre?
So if we take the x-ray, we could see a fracture, right? But why are we taking the x-ray?
Something's wrong, got suspicion.
They have suspicion that there's, let's say, a fracture, right? They have clinical suspicion, right? They have looked at the person and went, something's not right here, right? Let's take the x-ray. I think you've got a broken bone. I think you got a fracture, right? Clinical indication is, said in another way, it's the reason why we're taking the x-ray, okay? Doctors always need to have a reason, right? We don't take x-rays for funsies, right? We take x-rays because physicians have a reason for it, okay? So the reason: fractures, dislocations of the radius or ulna, pathologic processes such as osteomyelitis or arthritis. These are chronic progressive diseases. Good. I also don't include technical factors. These are settings we make on our equipment: SID of 40 inches, image receptor size of 14 by 17 inches, no grid. If you don't know what a grid is by now, or you're too new, I won't go into it yet, but no grid. And KVP range, 65 to 75. Again, KVP is a setting we make on our machine controlling how energetic the x-ray beam is. Bigger body parts need a stronger x-ray beam. So KVP is a setting that we make to control that. Shielding, shield the gonads. But then, okay, now you're in the important stuff: patient position, part position. How do you guys think about these? What does patient position tell you? What is part position telling you? Like, not specifically for this position, but in principle, what are these two things telling you?
I think the part position is how you display the body part to get the best x-ray. And then the patient position, like what's comfortable and with the circumstances around the patient.
Yeah, I think that's a really good way to put it, right? For me, the way it makes sense, that was great. For me, all I think about is patient position tells me where they're at in the room. Part position tells me, now that I've got them where I want them, how exactly do I put that? How exactly do I position that part so that I can demonstrate things the best, right? Okay, good. So patient position, right, is seat patient at the end of the table, hand and arm fully extended, palm up. You can practice that just in front of you on the tabletop. That's the nice thing about the upper extremities, right? You can practice them as you're learning about them. So fully extended, palm up, okay? Supinated, otherwise. You're also not going to tell the patient to supinate their hand, right? What are you going to tell them? Turn your palm up, right? Straighten your arm out, turn your palm up. You won't tell them to fully extend and supinate their forearm. Use plain English with our patients. You notice that part position's a lot more in depth, right? Part position. Drop shoulder to place the entire upper limb on the same horizontal plane. Align and center forearm to long axis of the image receptor. That just means don't put it diagonally across the receptor. Put it straight along the image receptor. Ensuring that both the wrist and elbow joints are included. If you recall from the hand and wrist and fingers talk, right? We learned that if you're asked to show a bone, you also need to show the other bones that touch that bone, right? So if you're asked to show the forearm, radius, and ulna, you also have to show me the carpals, and you also have to show me the humerus, part of it at least, part of each of those, right? Not a lot. You'll see in the image, if you're looking at the text, you'll see the image of the forearm. It doesn't show a lot of the elbow or a lot of the wrist, just some of it, the joint space. Instruct the patient to lean laterally as necessary to place entire wrist and forearm and elbow in as near a true frontal position as possible. Because as we said earlier, right, some patients, I'm one of those people that I don't supinate super well, right? You notice that as I supinate, my shoulder has to kind of roll out, right? Some people are very flexible. They can just full supinate without rolling out that way, right? But what you want is you want the hand in true supine position, wrist in true supine position, and the elbow in true supine position. The epicondyles should be parallel to the tabletop. One of these epicondyles should not be further up than the other. Okay, so one's not low, one's not high, right? So we want to make sure everything is parallel to the tabletop, flat to the table. So you might need to laterally roll the patient a little bit to make that happen. Central ray, or CR, right? Where does our CR enter? It's just perpendicular, comes straight down, and enters at the mid-forearm. Collimate on all sides, leaving about an inch of collimated border to the sides of each of the forearm. And then what do you demonstrate? If you do it all right, you're going to demonstrate all these things. So evaluation tells us. And I'm just going to give you the short version that's on the screen here. We should include carpals to distal humerus. Humeral epicondyles in profile. Means we get to see the shape of them. Slight superimposition of the distal radial ulnar joint. We see that the radius and ulna down at the wrist end are not completely separate. Exposure factors are correct because I can see a black background. I can see the bright white bony cortex of the bone. That's the outer layer of the bone. I can see the medulla, or the center of the bone, as darker. I can see soft tissue, and I can make out all the joint spaces. If the bone just appeared white, that's underexposed. When I ask you to evaluate positioning, it should sound something like this. The long axis of the forearm should be aligned to the long axis of the image receptor, not diagonal. No rotation is evidenced by the humeral epicondyles visualized in profile. With radial head, neck, and tuberosity slightly superimposed on the ulna. Wrist and elbow joint spaces are only partially open because of beam divergence. CR and center of collimated field should be open to approximately the midpoint of the radius and ulna. What I don't want to hear is, this one's good, right? That doesn't help me at all, right? Maybe it is, maybe it's not good, but you got to tell me why it's good, right? So this radiograph is good or of diagnostic quality because I can articulate what I'm seeing with the positioning. I can tell you no rotation evidence by, the profile of the epicondyles. I see the radial head, neck, and tuberosity superimposing on the ulna. Got to be able to say why the image looks good. Okay. Let's talk next about. So again, you're filling these in as you go. If you miss something or I move on too soon, you can fill in the rest later. This won't be due till next class. If you happen to finish it today, that's great. All right, our lateral of the forearm. The lateral of the forearm and the elbow requires us to flex the elbow to 90 degrees. 90 degree flexion. What's another way to say 90 degrees? Not straight. So it'll be like 180 degrees is straight, right? So 90 degrees of flexion is a right angle. You're going to make a right angle out of the forearm and elbow, or forearm and upper arm. 90 degree flexion. We're very specific here. We don't want an 85 degree flexion. We don't want a 95 degree flexion. We want 90 degrees, okay? We need to get good at recognizing angles. Now, do you have anything near you that has 90 degree angles that you can use to help you? Like assume this is you, right? You're in the room positioning this patient.
Like a sponge?
You can have radiographic sponges. That's great. I've got my collimated field though. That has nice square edges, right? I've also got the image receptor. So I can use those to kind of reference like if I'm at a true 90 or not, right? And it's just going to be, you need to visualize it. Yeah, but maybe I think maybe hopefully I'm interpreting what you're saying correctly. Maybe you take a sponge, right? And you set, a square sponge, and you set it in here to catch the angle right.
I guess I just misunderstood you. I was thinking like just to help support.
Oh, gotcha. No, so I'm mainly just asking, like, if you don't know what 90 degrees looks like, right, what do you have nearby that you know is square, or square edges, right? Image receptor, collimated field, Central ray is all square. And then pretty quickly you'll just learn to visualize what a 90-degree bend looks like. Right?
I always use my calipers, but
Calipers are great, right?
in the corner, take it away.
Calipers, that's a fantastic one that I didn't think to mention. I have a caliper in here to show people. Maybe not. I'm not going to go right away if I don't. No, but anyways, you're going to have something, and then you'll learn to just visualize it with practice. This becomes even more important when we deal with the elbow. Flexion is very specific. All right, let's talk. So clinical indications won't change. Technical factors won't change. Shielding won't change. Patient position is a little different. Patient seated at the end of the table, this time their elbow is flexed to 90 degrees. I just sneeze. Okay, almost sneeze. All right. One super important thing with the forearm that happens a lot when you are a student is with the part position. Okay, messing up the part position. So let's read part position. Drop shoulder to place the entire upper limb in the same horizontal plane. This is a quick, easy mistake that lots of people make because the patient's seated. We put them in a 90-degree bend, but their elbows down and shoulders up. Right. This creates an angle to the upper arm. This is going to distort our view of the elbow. Distortion is a change in shape or size, so we're changing how it looks to us. This is also going to foreshorten, make it appear shorter, the humerus. Okay, so drop the shoulder. That's one mistake that is often made. Align and center forearm to long axis of image receptor to ensure wrist and elbow joints are included. That's easy. This next one, rotate hand and wrist into true lateral position to prevent and support to prevent motion if needed. But often what happens, it's a tiny difference, right? Patients will often drop their palm down, okay? You have to remind them, or remind yourself, that true lateral is with the palm up. I tell the patient, give me a thumbs up usually, okay? Give me a thumbs up and they do that, right? But if you leave the palm down, that will change where the radius is, okay? That'll change its position, block anatomy, block other structures, otherwise change our view. Now we're not, we're going to get kind of a lateral up here at the elbow, right? But we're not going to get a lateral down here, and we're certainly not going to get a lateral in the shaft, the long shaft of the bone, right? Basically now this is just like a backwards AP with the bones crossed over each other, right? Not good, yeah? So we want the true lateral, that way radius and ulna are stacked on top of each other. Okay. Central ray doesn't change. Perpendicular to the image receptor, straight on down, and directed to mid forearm. Collimation, you need to include the elbow joint and the wrist joint. Let me be clear about this. The way they've presented this image is wrong. This needs to be rotated clockwise 90 degrees. We view the forearm, the lateral, as if the patient was standing in front of us, like that. Okay? When the patient stands in front of us like that, forearm is horizontal to the floor. This whole thing needs to be rotated. I think they did it so it fits on the slide. Okay, but to evaluate it, you are going to see a lateral projection of the entire radius and ulna, carpal bones, and elbow. Distal humerus are visible. Pertinent soft tissue like fat pads should be visible. Positioning evaluation, you know it's good when they have the long axis of the forearm aligned with the long axis of the image receptor. Elbow flexed to 90 degrees. You could put a protractor up if you like, right? Any angle finder and see that it's 90 degrees, right? Or use the collimated borders to help you, right? But it's a 90-degree angle. No rotation is evidenced by the head of the ulna being superimposed over the radius. That's down at the wrist end. Radius and ulna are stacked on top of each other. Humeral epicondyles should be superimposed. We look at the distal humerus and all we see is just the distal humerus. We don't see separation. Radial head should superimpose on the coronoid process. Remember the ulna, right? Like that. Where my thumb is the coronoid process for the ulna. That stuff here. And the radial head sits on top of it. CR and center of collimated field should be midpoint of radius and ulna. And you can see black background, soft tissue, fat pads if they're there, and different densities within the bone. Shouldn't be white bone. Okay. That's our forearm series. 2 views, easy peasy. Let's get into the elbow now. For the elbow, I want to mostly discuss part position and then evaluation. Okay, so I'm going to be a little bit more brief with this. But let's talk about the AP elbow full extension first. Okay. Clinical indications don't change. Technical factors very similar. We use a smaller image receptor for the elbow because it's just a smaller body part. But let's review part position. So assume we understand that the patient's going to be seated at the table like they are for like all of the upper extremities, right? They're seated, but so for the part position, okay, we want to make sure the patient can extend their elbow, supinate their hand, and align the arm and forearm with the long axis of image receptor. If they cannot fully extend and supinate, then we're going to have a hard time doing the full extension AP elbow. We're going to have to do something different, okay? What we don't want is full extension with partial supination, like neutral. This is my thumb up right here. This is neutral rotation, true lateral, right? We don't want that, okay? We want full supinations. We definitely don't want pronation. If they can't fully supinate, then we're going to have to do something different. If they're stuck here, we're going to have to do something a little different, okay? Often partial flexion allows them to supinate more, and then you can do the partial flexion views, which will be coming up next. Okay. Ask the patient to lean laterally as necessary for true AP projection, as necessary. Flexible people won't have a problem with this. Palpate the humeral epicondyles to ensure that the sorry, I thought I was reading that wrong for a second. The interepicondylar plane is parallel to the image receptor. You feel the condyles and make sure that they are both equally distant from the image receptor. Support the hand as needed to prevent motion. Often we have to weight, not often, sometimes we have to weight the hand down with like a sandbag or something to keep them from moving. People get a little shaky sometimes when you ask them to supinate and keep their arms straight. It's like that. Especially, I swear, maybe you guys have this experience. If you ask somebody not to move, all of a sudden they like concentrate on not moving and then they start moving, right? Sometimes you just put them in position and don't say anything and they don't move, right? But I swear to you, as soon as you say don't move, they like focus on that body part and it starts to move. Your experience may differ. Okay. Let me, because it's coming up next, let me show you what to do if the patient cannot fully extend and supinate, okay? We're going to call this partial flexion. So here's the wrong thing to do. Before I get to that, the absolutely worst thing to do that I've seen some x-ray techs do, the patient can't go into full extension, they're stuck in partial flexion. Please do not put the olecranon down like that and then do just one image, okay? Both the forearm and the humerus are not parallel to the receptor, so there's just no good image of anything, okay? This is terrible, so don't do that, okay? If you need to do partial flexion, we're going to do it just like this. It's 2 separate images, okay? They're stuck in partial flexion, so you're going to do one image with the forearm parallel. Let the central ray go straight in. Put the head out of the way, but let the central ray go straight in, okay? And then after you do that one, keep them in that same flexion and do one with the humerus parallel, okay? That's going to produce 2 images. One of those images is going to give you a good view of the humerus. One of those images is going to give you a good view of the forearm. Combined, they give you a good view of both things, okay? We ideally just want the patient to be in full extension to begin with, okay? But this is a way out of it, right? Notice what they did to help the patient, right? Often if they're stuck in full partial flexion, like they're not gonna move, so I don't usually put a sponge because they can't, they're stuck here to begin with. But if it causes them pain, if they're in more pain trying to hold that position, radiographic sponges can help. These sponges, again, do not show up on the radiographs, so that can help. You also see the sponge being used here to support the hand so that the hand doesn't drop like that. Humerus parallel to the receptor, forearm elevated. The next one, forearm parallel, humerus elevated. So those are the options.
Okay, sorry, no question.
Go ahead.
So if your doctor orders 2 views of the elbow or whatever, is it okay to continue, like?
Oh yeah,
stuck-
absolutely.
So you just do what you need to do?
You're gonna end up with 3 views of the elbow. Yeah. So they often what and you guys can confirm this or not, but often when an order comes through for, like, let's say the elbow, it'll say 2 or more views, right? So we call it a 2-view elbow, but the computer labels it as 2 or more, right? And yeah, the or more part of it is if you have to adapt for patient condition. Yeah, that's totally normal. I remember I think you had a question last class, like if it's okay to like add on, right? When we think we need to add on an image, I said probably not. Talk to the doctor, right? In cases like this, you add the image to get the complete exam, right? Yeah. So in the case of partial flexion, you'll need that extra image. Good. So let's evaluate. Maybe we'll evaluate it. There's not a good. Well, we'll just leave it on there, and I'll read the evaluation. Okay, so I'm just going to read the evaluation for the AP. Long axis of the arm aligned to the long axis of the image receptor. You see how that shows up on every single one as the first thing you're saying, right? That's step 0, right? And then we say no rotation evidenced by the appearance of bilateral. That means both sides. Epicondyles seen in profile. Radial head, neck, and tubercles separated only or slightly superimposed by the ulna. We should see radial head, radial neck, and radial tuberosity kind of touching the ulna. Okay, that's how we know we're in AP and we're not like externally rotated or medially rotated. They touch each other. So the AP is not a good view of the radial head. It shows it, but it's not the best view. Olecranon process should be seated in the olecranon fossa with the arm fully extended. There's our olecranon process within the fossa. Elbow joint space appears open with fully extended arm, proper CR centering. CR and center of collimated field should be to the mid-elbow joint. Okay. The same thing is true of the partial flexion series. It just takes the 2 images to get all that information. Basically, like with the forearm parallel, you're just evaluating radius and ulna. With the humerus parallel, you're just evaluating the humerus. Together, you get the full picture of the elbow. Let's talk about our obliques. We have a medial oblique and a lateral oblique. Oh, let me humor me for just a second. Go to page 166. So, you guys, we just talked about AP partial flexion, patient stuck in partial flexion, right? But you might get the circumstance, and this is not one of our assigned ones, so don't fill this in, and it's not shown on screen very well, but on 166 in the textbook, the acute flexion projection of the elbow, okay? Let me read from this and see, and show you what's going on here. So acute flexion, the patient's stuck like this, okay? I've only had this happen one time when a patient was stuck like this, and they just could not come out of extension, okay? They had, I forget what was broken, there was something really wrong though, radial head or olecranon fracture, but anyways, they were stuck like this, okay? And so with this, we can't do one with the forearm parallel because the whole body goes over it, right? And we kind of have a pretty hard time doing with the humerus parallel, right? Because this is all overlapping, okay? So how do we get any information at all? Turns out we can get something. So let's talk about patient in part position. They're seated at the end of the table with the acutely flexed arm resting on the image receptor. So you bring them like this. Oh, little puppy. Set them on the receptor. Okay, just lay them like that. Okay, both images. There's two images involved in this. Both of them are going to leave the patient like this. Okay, with the patient like that. For image 1. Well, let me read part position first. So align and center humerus to long axis of the image receptor, forearm acutely flexed, fingertips resting on the shoulder, like that. Okay. Adjust image receptor to center of elbow joint region, kind of in the neighborhood of the elbow joint. Palpate humeral epicondyles to ensure the humeral epicondylar plane is parallel to the receptor, so we don't want them like that. We don't want them like that, right? We want them like that. Okay? Good. Now comes the two differences. What you can do is you can get one image showing the distal humerus, the other image showing the proximal forearm. The way you do this is by putting the central ray for image 1 to view the distal humerus. You're going to put the central ray perpendicular to the humerus, okay? And the humerus is parallel to the table. So the central ray is just going to come straight down, okay? And your best image is going to be of the humerus in this case. You'll see that in figure 4.129, okay? You get to see the outline of the distal humerus. It's not a great image, is it? But it's something, right? It's information. Next, your second image. You can see this in figure 4.128. CR for the proximal forearm. Direct the CR now perpendicular to the forearm. So you get the trick, right? To demonstrate the humerus, central ray is perpendicular to the humerus. To demonstrate the forearm, central ray is perpendicular to the forearm. You have to angle in, right? The forearm, let's look again. The forearm is at an angle to the table, right? So the central ray cannot come straight down. It has to come at an angle to the tabletop, but perpendicular to the receptor, to the forearm, like this. Okay, angled. In an image 4.130, we get to see the outline of the olecranon and something about the radius. I don't have a good image to bring up on the screen for this unless I do. Oh yeah, good. So this one gives us the shape of the distal humerus. Now I get to see the humerus, right? And this one lets us see the olecranon, and I can even see the radial head superimposed on the distal humerus. I can see what I need to see. It's not a great view of either, but I can see something, right? Something's better than nothing. So this is a better than nothing kind of option, okay, if they're stuck in acute flexion. All right, let me move on now. Let's go to our medial and lateral obliques, which are the actual assigned positions. So that's a position you might need to get used to. It might come up. Okay, so for the obliques, let me find the right page for this. The obliques are going to be found on, are they both found? 169. Oh, okay. 167 and 169 have the obliques. Got it. I'm on board now. Let's talk about the lateral oblique first, which is the one shown on the right here. All right, so both of these need the patient to be able to get into full extension and full supination, okay? So if they could not do the AP fully extended, then you can't do these images. But if the patient can go into full extension, full supination like this, then the lateral oblique and the medial oblique open themselves as options to you. Sometimes the physician will order a full or complete series of the elbow, which will involve these obliques, okay? The word oblique just is referring to a position between lateral and AP. Okay, we call them like angled or rotated positions. Okay. The lateral oblique. Let's look at the clinical indications because this will kind of illuminate why we do why we have this separate position. Fractures and dislocations of the elbow. That's not that exciting, but primarily the radial head and neck. So what's this position for? I just said it. Radial head and neck, right? We have an AP elbow. We've got a lateral elbow for the rest of the elbow. We want to see the radial head and neck. This lateral oblique can give us that, okay? So to shorten this up, let me just go straight to part position. The arm is straight, aligned to the long axis of the image receptor, central ray centered to the image receptor, elbow centered to the image receptor. The real work comes in where we say, supinate the hand and wrist, like an AP, but then rotate laterally the entire arm so that the distal humerus and anterior surface of the elbow are approximately at a 45-degree angle to the image receptor. So what I like to do when I show this is, I'm doing it right now for you, put a pen right here. The pen is representing the angle of my anterior surface of my elbow, right? And right now the pen is parallel to the tabletop, right? But if I roll laterally that way, the pen now makes an angle to the tabletop, okay? The pen is roughly at a 45-degree angle to the table. This is lateral rotation. With this lateral rotation, 168 gives us our evaluation, but here we have it. With this lateral rotation, the primary things that are going to be different from the AP here is that with lateral rotation, we get separation, because normally the radial head, neck, and tuberosity touch the ulna, but with that extra 45 degrees of lateral rotation, they're now going to separate. Okay? Radial head, neck, and tuberosity are free of superimposition. They're moved away from the radius and ulna. Radial head, neck, and tuberosity are now in profile. Lateral epicondyle, capitulum, and profile. So that is our capitulum. But most importantly, this is for the radial head, neck, tuberosity. Okay. That's the lateral oblique. Now let's go to 169 and look at the medial oblique. This one's so easy. The patient goes into AP, right? And then all they're going to do is pronate the hand. Okay? So it's just an AP with the hand pronated. When you do that, now watch the pen as I do that. It rolls the pen, right? The pen is parallel to the receptor. Pronate your hand. The pen is now at a roughly a 45-degree angle to the image receptor. So this medial oblique is really just internal rotation or pronation of the hand. Let's read clinical indications because that will tell us why have this separate view. Fractures and dislocations of the elbow, sure, but the important part of this is primarily the coronoid process. This image is to see the coronoid process better. Part position. So I just showed you, but let's read it. Align and center arm, center to the image receptor, long axis aligned to the image receptor. Good. Pronate hand into a natural palm down position. Rotate arm as needed until distal humerus and anterior surface of the elbow are rotated 45 degrees to the image receptor. Palm down. Our evaluation. We see pretty quickly, there's our trochlear notch. This deal here, there's our coronoid. Look how good of a profiled view. You get to see the shape of the coronoid process here. Notice we don't get a great view of the radial head, neck, and tuberosity. But that's okay, right? Because we have a separate image for that. We have many separate images for that. Radial head, neck, and tuberosity. Trochlea is in profile. Medial epicondyle is in profile. There's our medial epicondyle. All right, let me jam through last two positions. Let's go to lateral elbow on 170. Lateral elbow is part of if they order a limited series, or what we'll call like a 2-view elbow. It's an AP and a lateral. Those are your two minimal images. You need at least those two to be a complete exam, okay, or even a limited exam. They're done for fractures and dislocations of the elbow. Let's go straight down to part position. Align long axis of forearm to image receptor. Center elbow joint to image receptor. Drop the shoulder so that the humerus and forearm are in the same horizontal plane. They say this over and over again because this is one of the biggest mistakes with elbow imaging is keeping the shoulder up. You have to lower the shoulder down. It just won't come out good if you don't. It won't come out correct at all. That'll be evidence when we get into positioning evaluation. Rotate the hand and wrist into true lateral. Always thumbs up, just like the lateral forearm. Place the interepicondylar plane perpendicular to the receptor. That's already done if your parallel humerus and forearm are parallel to the receptor and your palm up. The intercondylar plane is already perpendicular. Place support under the hand and wrist to elevate the hand and distal forearm as needed for heavy muscular forearm so that the forearm is parallel to the image receptor. You guys have seen Popeye the Sailor Man, right? The cartoon, right? Popeye's got massive forearms, right? You put Popeye on an image receptor and his hand and wrist are going to droop, right? Support that hand and wrist, okay? All right, let's look at our evaluation. I'm going to read from the longer explanation here, but we're demonstrating distal humerus, proximal forearm, every associated bone there in the joint, long axis of the forearm aligned to the long axis of the image receptor, elbow joint flexed to 90 degrees, about 1/2 of the radial head superimposed on the coronoid process. So the lateral doesn't give us a great view of the radial head. It's an okay view. If there's obvious fractures to the radial head, we'll see them here, but it's not a great view. We have separate views for this. It's also a terrible view for the coronoid process. It completely superimposes the coronoid. So if we're worried about coronoid fractures, which I'll tell you are just kind of rare, but they happen, we're not going to see it. We might, but if we get lucky, but it's not plainly visible. True lateral, indicated by 3 concentric arcs, trochlear sulcus, and double ridge of the capitulum and trochlea. We've covered that. That will not show up if you don't drop the shoulder. You have to keep the shoulder low. Superimposition of the humeral epicondyles, and we're centered to the elbow joint. So that's our lateral. Biggest thing with this is make sure we're at 90 degrees of flexion and the thumbs up. If you do those two things, you're going to have a hard time getting it wrong. All right, our special projections, only one of them will show up on the state board, and that for whatever reason is called the trauma axial lateral, the coil method. State board will not give you acute flexion questions and will not give you special radial head questions, okay? Even though the coil method is specifically for the radial head. I don't know why they differentiated that. But anyways, let me show you the coil method, okay? The coil method has 2 different positions. And these are done in either 90 degrees of flexion or 80 degrees of flexion, and different central ray angles and placements depending on what we're looking for. If I want to see the radial head in the case of trauma, and the acute partial flexion views, I can't see it very well, right? I can put the patient into flexion because they're already stuck in flexion, okay? And I can use my central ray, my X-ray tube angling. I can use that to purposefully distort and elongate anatomy so that I can see it better, okay? If you're on 171, you're seeing some of this already. If I want to see the radial head, and you'll notice that there's 2 different part position explanations. Part position 1, radial head and neck, elbow flexed to 90 degrees, hand pronated, CR entering at 45 degrees, angled toward the shoulder. There's our CR coming in at a crazy angle, 45 degrees. So instead of doing this whole full extension lateral rotation thing like we do for the lateral oblique, patient can't do that. So we pronate their hand, so the radial head rolls this way, and then instead of coming straight down, we come in at it from this way. So it projects the radial head elongated, okay? And you can see the image. I won't go off of the screen what I have right now. 4.148 shows you that image in the text on 171. if instead you would rather see the coronoid process in the case of trauma. 80 degrees of flexion, so instead of 90, they're like that, okay? Less flexion, about 10 degrees less flexion, and instead of angling toward the shoulder, we're going to angle 45 degrees going away from the shoulder. And that gives you 4.149 in the text, gives you that image, shows you the distorted view of the coronoid process. Either way, they should provide a elongated, distorted view, but free of superimposition. One of the radial head, one for the coronoid process. Okay, gang. Let's take a short, quick little break, about another 5 minutes. Let me reset. We're going to do another an activity similar to what we did last time, and but